Thanks for coming to the Surmodics luncheon on the Pounce device. I'm Dr. Gary Ansel. I've got an esteemed group with me to help do hopefully one of the more interesting lunch sessions you're going to see, because we think it's truly an exciting time back into vascular therapy. I know you guys some are just sitting down, but we're going to go ahead and get started in the matter of time. But I want to thank Surmodics for helping to sponsor this, and for ISIT for being here again this year in the beautiful Miami. So this is my physician panel. Again, Dr. Sean Lyden, who's head of vascular surgery at the Cleveland Clinic, Lucas Ferrer Cardona, who's a vascular surgeon at the Dallas Sexton Medical Center and the University of Texas in Austin, and then Dean Ferrera, interventional cardiologist at the Community Hospital in Munster, Indiana. These are our disclosures. I probably got the biggest one because I helped develop the Pounce device, and so I will obtain royalties long term. These are the indications, contraindications for completeness, but you'll see that there's two different ones for the Pounce, and there's now a Pounce LP that we'll talk about. So I'm just going to do a quick system overview, because sometimes you want to know, where the heck did these come from? Is it just some engineer who tried to come up with something a little different? Well, this isn't. This was helped develop by physicians who did acute limb ischemia on a regular basis, and we had the same pain points you have, which is, when am I done? Did I take out too much blood versus how much clot did I get out? Or how do I get that last bit out, the really organized stuff, or the embolus? I mean, this patient had an occlusion of their popliteal, and then we took it out with aspiration thrombectomy, and we got to this. Now, I know you've all seen that, right? You get to that point and you say, all right, how much blood have I removed? Can I keep working at it? Should I stent it up against the side? Do I send them for an open Fogarty, or do I have them get thrombolysis and send them to the ICU? I mean, this is not an uncommon occurrence. So this one, we actually got a piece of it out, and this is what it looked like. It looks like a pencil eraser. And this is always the Achilles heel of every aspiration-based thrombectomy that's out there. Why? Because I've used them all, been there, and this is just the way it is. So I wanted to come up with something, because these were long cases. I don't know how many of you are techs and nurses, but they hated these cases. Why? Because they were a long time. You were taking out a lot of blood. The patients were sick. So I wanted something that was simple, so I'm not yelling at my tech, gosh, what do you mean you don't know how to hook that cassette up? Those kind of things. I didn't want to change what we did. I wanted small profile. I wanted it fast. I didn't want to take out blood. Why? Because the patients feel terrible for 2 months after that. And then I have to, transfuse them, and then they feel terrible, and I'm getting a ding from Medicare. I wanted to be able to quickly deal just with every thrombus out there, acute to chronic. And I was a part-time administrator as well, and I didn't want a power unit. I didn't want to go through the silo of a capital purchase where I had to continually pay for upgrades in the machine and the service and education, those kind of things. So that comes to the Pounce. Now, there's two Pounces out there. I think this one on the left is really a game changer, because we really haven't had a tibial device that works. Once something goes down the tibials, you probably all do like us. You kind of go, oh, no. Am I going to stent this thing up against the side and a tibial? What am I going to do? Am I going to try to lyse it? Most of the time it's organized, so it's not going to happen very quickly. Or the one that we're all have just been around for now a couple of years, the Pounce thrombectomy. They have different diameters. The one is a tibial, and the one's a fempop. What is it? You guys all thought of this at some point in your career. It's a percutaneous Fogarty. How do I do a percutaneous Fogarty? Because if I just had that, I'd be home. And so I thought about this long and hard. It took me 13 years to figure out how to get this on label and all that kind of stuff. But, the first concept is a plastic funnel and a balloon. Mimic the Fogarty. That doesn't work. And not if you don't want to aspirate, because the hydraulics work against you. And you'll say, why 2 baskets? Because I wanted it fast and efficient. And the funnel isn't a plastic funnel. It's a double wire nitinol mesh. Why? Because what are we mostly made of? Fluid. If I can get rid of the fluid, what I'm taking out isn't as much. And you'll see that on the cases. So I didn't want to change what we do. If you got a clot, we typically win through it with a hydrophilic wire. we would take down a catheter, and then we'd usually switch out for a wire or a small wire to put in a rheolytic thrombectomy or another aspiration device. Well, now instead of doing that, through that catheter, we put these two baskets that get, they're self-expanding nitinol. You'll be amazed how little radial force there is. There's more than the carotid distal protection because we had tried that. We knew that only worked on very rarely. So they're a little more robust then. And then you just pull this back into this funnel and you lock everything down. And as you aspirate or bring it back, not aspirate, but as you pull it back, the fluid is extruded, but you'll see that the risk of embolization is not due to these open interstices. You'll see it's because of the funnel. They're very small, so the risk of embolization is extremely small. So for that, I can just tell you that this is an exciting device for me because I wanted it simple for you and me. I'm going to turn it over to Dr. Sean Lyden about treating a popliteal arterial embolus with the Pounce thrombectomy. Sean?
So thanks, Gary. I'm going to be part of the one co-national PIs for the registry looking at outcomes with this, which hopefully will then help define how this device is best used, and I'm compensated for that for disclosures you saw. So I'm going to show you two recent cases. This one's from Tuesday. So, this was not part of what I was going to talk about, but, hey, you always have a new disaster that happens. So this is a 62-year-old gentleman who I'd been following, who had a type 4 thoracoabdominal aneurysm that now has got to 6 centimeters, and his proximal left condylar artery is 3. His aneurysm is really saccular and it outpouches right at the celiac. And you sit there and say, well, why not a endovascular solution? Well, unfortunately, he's got a 1 3 millimeter left renal and a 1 3 millimeter right renal artery. So really any kind of custom endovascular solution is not likely to preserve his renal function. He's otherwise 62 and pretty healthy. So we worked him up. His heart was actually pretty strong, so we decided to do open repair. And just of note, his distal aorta, which is only 3.5, it's not huge, but it's just really kind of calcified in a rock. And for anybody who's a surgeon in the room, you know that those are not necessarily a lot of fun. So we did an open bifurcated repair with an 18/9 graft, which comes into what we'll play later. I ended up endorectomizing his right renals because there was calcium at the origin, and endorectomized his left renal, put in as a Correll patch. He had good pulses in his pelvis. He had good pulses in his groins. We finished. So usually when you do someone in a retroperitoneal position for a thoraco, a lot of times the left leg doesn't look as well perfused. You turn him flat. Turned him flat. Now it looked terrible. He had no signals. I was like, oh, crap. So my room that I work in is both an open and a hybrid room, and the tables are about 12 feet apart. So we took him off table A, put him on the hybrid OR table, put the duplex on his groin. His groin was still patent. When I'd sewed his left iliac limb, trying to cut away some of the calcium and sew to it, it kept, the calcium kept breaking apart. Anybody's a surgeon room know what that sinking feeling is like when you're trying to tack that up. And usually when that happens, a lot of times when you notice it immediately, you can just put a self-expanding stent there and be done. So I put my 7 French sheath up. You can see I'm past the limb. I'm injecting flows going down the other side. I pull my sheath down into the limb, and you can see now I have some thrombus that's formed within my limb. And from just straightening out the external where it's not calcified, it kind of looks kind of janky-janky. The limb is a 9, and so the Pounce is really not indicated for this. So with the 7 French sheath, I just took out a Cat D. It's one of my go-to mechanical thrombectomy devices. Ran the Cat D up and down a few times, and you can see the picture on the left of the picture on the right that I got a lot of the plaque out of the anastomosis, and then I threw a self-expanding stent in, but I still had some thrombus above there, so I then took the Cat D for a couple more minutes, sucked it all out. Fresh clot, works well. You can see, unfortunately, with putting the self-expanding stent without angioplasty, I did lose my hypogastric. And then I said, all right, well, let's look at the runoff. So, feeling really happy. I don't have the foot prepped in. It's covered. You can see the external now looks okay. Common femoral SFA profunda looks okay. Coming down, and now it just stops. So now I'm wishing as a surgeon I hadn't done this all percutaneously. I wish I did a cut down because I could just, go work the other way. And so I decided to flip the sheath, which anybody who does it either works spectacularly well or ends horribly. In this case, fortunately, it worked really well. So I was able to take my 7 French sheath, with a VCF, turn it around, flip it so I'm heading down. And so since I already was using a mechanical aspiration device, I put it down, and I used the penumbra system quite a bit and was able to engage it, but just really could not get rid of any more than this. So I got out the popliteal, but you can see there's still a bunch sitting in the origin of the AT and sitting in the TP trunk. So then I just took the Pounce and was able to first pass it down into the PT. You can see here's that microcatheter system into the PT. First pass into the PT, you can see it's got rid of almost everything. Unfortunately, he did have a little bit go down into the perineal, so a second pass into the perineal. And then the guy had a palpable pulse. He actually is going home today. So I just called about an hour ago to see how he's doing. And so to me, this was really with very, very minimal blood loss. This took like 10 minutes, and my entire team was, wow, how'd you do that? Now, I did try to turn the sheath one more time so that I didn't have to hold pressure, but on the second flip, it didn't work. So we held pressure for 30, 40 minutes. So, like I said, he's actually going home today with palpable pulses in both feet and doing well. So I'm going to talk about one other case, another recent disaster. So this one was my partner's. It's a 40-year-old woman who's had a history of a lower extremity sarcoma in her left leg. She had prior resection. It involved her bone, and they basically took her distal femur, her knee joint, her proximal tibia, and her proximal fibula. And she has some AFib and now presented with a couple-day history of acute limb ischemia with some motor loss. So my partner had gotten a CTA runoff, and there was a lot of scatter because of the all the hardware. You can see here, she's got a rod in her femur that comes almost all the way up, and you can see the artificial knee joint and then all the screws in her tibia. So on her CTA, she was clearly open to the distal SFA pop, and because she had motor loss, he actually decided to take her surgically, and so he actually tried to expose the above knee pop artery, and it was just because of the prior tumor. She'd also had a ton of irradiation. It was completely encased and stuck. Because of the 2B ischemia, he then did fasciotomies, and then this is also the same day when I'm doing my thoraco, and he goes to me, he goes, "Hey, can you come over here?" And I said, "Well," he goes, "what do you think about lysing her?" I said, "Well, now you have an incision in the above knee pop and have done fasciotomies. I don't think lysis is really a great idea. You're worried about the duration of ischemia." And I said, "So how about we, use the Pounce?" I said, "I just used it, worked really well for me." And I said, "Well, grab a 7 French sheath." I usually try and tell people to use a Terumo sheath because you can disconnect the valve. And I said, use a 7 French sheath. One of my younger partners who's never used the device made him put an 8 French 70 cellular Cook sheath in. So I come in, I'm like, where's the Terumo sheath? He goes, "Oh, we put in an 8 French. And I'm like, okay. So it was really hard. And so I don't have the greatest pictures. I apologize because her leg doesn't move much. She's the better part of 50 BMI. And so trying to turn the II to get and see her distal runoff, you can see there was a hint of a perineal blood vessel. So we were actually able to, turn the eye as much as we could, go through the popliteal clot, get into her tibial vessels, was able to get down in the perineal. And this is my first pass. So like Gary said, we got the bullet, and this was all the thrombus that had formed above it. And interesting enough, after I got doing that, I opened up the valve on the Cook sheath. Now it's an 8 French sheath. The 8 French sheath still had no flow. And so we had actually pulled out so much stuff that I actually had to take the whole 8 French sheath out and flush it because of how big the burden of clot was in this lady. And then we made a second pass down in her posterior tibial vessel, and you can see now we have 2 vessel runoff. And so really, to me, the gap I came out of this was I know that there was an LP device. I made some calls saying, when can I get it on my shelf because I don't have it? But it's just 2 quick cases just showing how versatile this can be and how quick this can be. And, this lady had already had a surgical cut down. I'm a surgeon. Surgery works really well, but I told them in an irradiated field, with that going on, I would have been endo all day, every day. And so that there is going to be we're currently involved in a registry. It's a retrospective. It's open label. It's multi-center. It's going to be a 30-day follow-up looking at acute outcomes. And so we're going to have up to 500 patients at 30 U.S. sites. Joe Campbell, who's an interventional cardiologist at Riverside Hospital, Ohio Health, is my co-national PI. And so the primary endpoints we're looking at is efficacy. Is the procedural successful or not? And then for safety, we're looking at the incidence of major adverse related events. And then for secondary endpoints, we're looking at the efficacy of the device. Was it technically successful? Was it continued to patent through 30 days? How complete was the thromboemboli removal? And for safety endpoints, were the device-related MAEs and all-cause MAEs. It is going to use a core lab. I think that's going to be one of the strengths of the registry, so you can know that the films have been adjudicated. And I'm happy to say it's actually up and running and collecting cases. And I'm hopeful that both my two patients from this week actually agree to have their data submitted to be part of the registry. So with that, we do have some other cases that will actually highlight some of the tibial stuff. And so I'm going to first call up Dr. Ferrer Cardona, who's going to talk to us about some of his cases.
Hi, thank you for having me. And here I'll present two quick cases. The first one is more of a thrombectomy pathophysiology, and the second one is more of an embolus pathophysiology, which is kind of what we see every day in our clinic. And these are from my most recent week on call. So, we get these pretty often. So the first one, obviously, is our typical smoker, long-term smoker. I do an outreach clinic, kind of like in the boonies in Central Texas. And what I get is, farmers that smoke. And he's had claudication and worsening rest pain until he just can't take it anymore and comes to my clinic to be assessed. So at that point, he had acute limb ischemia, admitted, taken to the operating room. So on our initial angiogram, what we see is what we expect to see. Basically, the SFA is down, and you have some degree of reconstitution at the level of the TP trunk. Here, our guide wire obviously goes pretty easily, although you can tell by the movement of the guide wire that there is some chronicity. There is obviously atherosclerosis, given the nature of the pathophysiology of the patient. So at this point, I've been working with Pounce for several months, and it seemed like an appropriate use, given the size of vessels and the nature of what I thought that this thrombus was a mixed thrombus. So here you can see I used IVUS, made sure that the tibials, the ostium, which were involved, were of adequate size, and we used the Pounce I call it the OG Pounce. And at their first pass, you can see that some of the thrombus is obviously gone, but you can see the chronicity there. We did several more passes. Obviously, treat the SFA with angioplasty and required stenting above the knee. But at the end of the day, we had inline flow down to the foot. His symptomatology of rest pain was resolved, and he went home as any other patient would go, which in an elective kind of fashion, where you kind of have confidence in your ability to have technical success. And I think that's where this device kind of changes things. It gives a little more predictability as far as your success rate. I feel more comfortable with these type of cases, which, to be honest, thrombus always kind of makes me uncomfortable. And here our second case. Now this is kind of the typical angiogram you see when you have an embolic source. And basically this patient came in with acute CLI, skin changes, leg is threatened. So again, heparin in the ED and immediately going to the operating room. The wire went much more smoothly, again, going with the kind of more embolic nature of what I thought was going on. Again, we placed the Pounce. And this case was very interesting because the main outflow was the AT. So I did a couple passes in the TP trunk, and I didn't get what I expected, which was complete resolution, although I got significant clot. And then I passed it into the AT, and the main chronic plug had plugged into the AT. And then he had some more chronic disease in the TP trunk, and I just treated that as I would treat any other type of chronic tibial disease, and improve his TP trunk and PT significantly, where the main flow was then through the TP trunk, but he got 3-vessel runoff out of this procedure, and his leg was immediately safe and in a non-threatened fashion. So, I think the benefits and why I've incorporated this device is that it makes my life easier. Again, when I have these cases, I'm not as nervous. I'm not thinking that I'm going to need to put this patient in the ICU, take him back the next day, all those thought processes which we can associate with thrombus or large amounts of thrombus. So yeah, thank you.
Great. Nice cases. Pleasure to be here and discuss some cases with the panel here. Go through a couple that I've seen. In my world, as an interventional cardiologist, I have surgical backup with surgeons that don't do much endovascular. So we're kind of the first line call for a lot of issues as well. We approach as a vascular care team. My first case is a case of ALI. So I had a 75-year-old gentleman who unfortunately decided to leave Columbus, Ohio, drive towards Chicagoland area. And while he was en route, he felt a lot of palpitations in his chest. Took a stop at a gas station, then realized he couldn't feel his foot very well, so decided to stop driving his truck, fortunately. He called EMS and then came in, and he had some symptoms off and on for about 1 day, but it was pretty clear that the patient was in atrial fibrillation, which was a new diagnosis for him. And on top of that, he had these decreased pulses in his foot on exam, so an arterial duplex was done, which showed some abnormalities of flow with occlusion in infrapopliteal region. This was all confirmed to be a case of pretty much a 2A ALI Rutherford class, and so he was immediately started on medical therapy in the emergency department. We then were involved and brought him into the cath lab. We thought it was a good case because we didn't feel that he was high risk for fasciotomies. In coming into the lab, first angiogram shows a pretty clear plugged occlusion of the popliteal artery with just scant vasculature in the infrapopliteal region. You do see a little blush of the AT there. So we have an occluded P1 segment of the pop down, occluded TP trunk. We have an occluded plantar branch, of course. Don't see much of that at all, but just some reconstitution at the ankle. It looked more chronic, frankly. But we had no flow via the peroneal, and the AT looked like it was going to come back. It looked like there was clot there. So the plan was to go ahead and thrombectomize this. Given the patient's presentation and good landing room, we felt that Pounce was a reasonable device for this case. We went ahead and crossed, as expected, very soft clot, easy to cross. Now, in this particular case, we were with the, as Lucas said, the OG device, but we had a nice size tibial system. It had measured out about 3.5. We did confirm that with IVUS. I was able to get down easily into whichever vessel I liked, fortunately, and I used the funnel here to protect the remainder of the below-the-knee tree. So the funnel itself was first deployed in the AT proximally while a pass was made from the mid-AT up. A similar technique was then carried out into just the proximal part of the PT, and then I could see that proximal cap. I suspected it was a chronic occlusion, and indeed it was. We had a little cleanup work to be done in the peroneal, so 3 total passes with the Pounce. We had a great result in those segments, and then I went ahead and crossed this chronically occluded peroneal vessel, and just simple angioplasty got a good flow down to the ankle there, and the patient went on with out of the cath lab with good patency in all 3 below-the-knee vessels. He did great. All symptoms resolved. Didn't need any other further treatment other than anticoagulation, of course, for his AFib case. Now, moving on, this was one of the earlier LP cases that I did. 70-year-old male, now with a chronic non-healing foot ulcer. Really a tough case, tough patient, chronic smoker. He had bilateral SFA occlusions and needed a common femoral endarterectomy at one point, so he had that treated surgically and ultimately had a greater saphenous vein graft placed in situ. He presented with more of a subacute situation. His wound was not healing. His pain had increased. He had some signs of infection, was hospitalized for all the above. My partner was on call over the weekend, got the first phone call. The patient's bypass graft was occluded, so he went ahead and took him to the cath lab, crossed through that graft pretty easily, and just used thrombolysis and did some follow-up thrombectomy on that. The final angiograms at that point showed a single inline flow to the AT. And because of the patient's graft occlusion, we had an upfront plan to bring this patient back, provide him with a little bit better outflow other than this one AT runoff for a right lateral foot wound. So at this case, I decided just to come in and really tackle the below-the-knee segment. It wasn't a planned Pounce case per se. Came down through the bypass graft in an integrated fashion, went ahead and put my IVUS catheter in after I crossed, and they saw some fresh clot still sitting in that TP trunk branch, and it looked like it angiographically as well. So in this case, we delivered our catheter all the way into the native system. You can see in the middle picture there, I'm slowly deploying the funnel. I just wanted to show that so we can protect the remainder of everything above. So that funnel's deployed in the TP trunk. And then on the last picture there, you can see just the technique, just a slow pull back, total of 1 pass, I believe, in this case. Took out some nice, more subacute, little chronic looking clot as well. Restored good patency. So this angiogram shows after 1 pass with LP, after PTA alone, and then I decided in this particular case to go ahead with a little atherectomy because of some of the IVUS findings there, and a final balloon angioplasty shows great outflow from the graft down to the below the vasculature, and then he had better flow down to the foot with good runoff and actually wound blush, which doesn't actually show up too well in this photo, unfortunately. Good case. So my final thoughts on Pounce. This is an efficient device. I think as Dr. Ansel said, I mean, you can kind of pull it on the fly, get great results with it. It minimizes blood loss. It's easy for staff to set up because it's all done on the back table. Patients can enjoy a better result early on. And, difficult patients require flexible strategies. So being able to incorporate this pretty quickly is definitely an added bonus, and it's complementary to other therapies. Thank you.
So before we get to the more couple last rapid cases, I know that Mike Backrack and Bruce Gray that do a bunch of the Pounce cases. One of the things that Bruce told me a lot is it's sometimes you use it for diagnosis, and that is just as Lucas's cases, sometimes you've got a mixture of atheroma and thrombus, and you take out the thrombus and then work on the atheroma. And if you take out the thrombus, then you can really be confident that you're not going to embolize when you're doing an angioplasty of a previous CTO. Is that your experience as well, Sean?
So like say if somebody who has got an SFA occlusion, but it's not something that clearly had it's been bothering for 24 hours or a week. It's something, they've been having, accelerated symptoms over a couple months, and you're able to cross and then pass this, two things you find. You actually open up areas where we're all clot, but you also open up areas where the atherometer is, and then you have a better idea of what you're going to do to treat. And I've always been a believer that if I have native vessel that's not so diseased, if I don't have to scaffold the whole vessel, I'm better off. So I actually enjoy the fact that it can really identify what the underlying lesions are, so you can move forward with the treatment of just the lesions that are causative.
Super. And I know the other thing that I'm not sure how many people realize this, but there was the STYLE trial, there was the Rochester trial. I mean, all those different thrombolysis versus surgery trials. And what people sometimes don't realize is that there were no emboli supposed to be in those trials. They were just thrombus. And currently, even in SVS guidelines, embolization is actually still considered to be an indication for Fogarty because you can just open surgical embolectomy because you can just do it so rapidly. In your own practice, since this takes out emboli as well, is there a reason to go to Fogarty very often, or do you typically go with the Pounce?
It's amazing. It's a big leap for me to get some of my partners to try it, but I've basically gone to anywhere and everywhere if I can do it percutaneous. It's equally as fast. You get better picture of the runoff. If it's down into a branch, you're able to get into it. So, a Fogarty embolectomy always works really well when it's in the main trunk, but when it goes down into the pop and into the tibials, for the surgeons in the room, I challenge anybody who sat there and said I had to cut down on each individual tibial branches to say that percutaneous is not a better way of doing it.
Super. And if the crowd has any questions, there's microphones placed around the room. You can feel comfortable enough coming up. You've got a great panel to discuss this with. Hey, Dean, one of the things that, again, being part-time administrator, when we had devices that had to be hooked into something or rolled in from another room, they had, some type of power unit. We had to actually include that in our educational processes so that the nurses and techs went through that on a regular basis. And I remember I almost tried to end my career several times when people were trying to hook things up and had no idea, when I'm trying to be politically correct and breaking scrub and going to hook things up. from your standpoint, for the nurses and techs out there, how difficult is it to learn the Pounce and maintain your education on it?
I think that's a great question. Overall, it's quick. I mean, this is a back table device, is how I term it. A simple case can be done pretty efficiently, even without a trained staff. And that's been happened time and time over in my lab, because I was the first Pounce user. And then we suddenly had a bunch of my other partners and other cardiologists start to use the device pretty much on the fly with a quick in-service. So the in-servicing is quick. The prep of the device is quick. The saving grace of it is that you don't have to send somebody back to another unit with thrombolysis running and more care to the patient. So you have that point of care that is really effective and efficacious, leaving the patient out of the lab or transferring the patient out of the lab with a resolution of the thrombus burden without any more need to follow bleeding times, fibrinogen levels, etc. So that part has been great. And so once you see that and your staff sees that, I find that, they're very quick to want to use the device. So they're almost going to it as a first pull, whereas they used to walk in with the ECOS machine, right? You used to see that come in the room and they would see thrombus. And now we see Pounce packages coming in.
Well, super. Thanks. We have a question at the microphone.
So it seems that this device is something that would often be used as an emergency device, albeit there are certain planned cases where you might use it. So if we have this on our shelf, it is possible we might be using it for the very first time at a time where there would not be a rep present. Is there someone from the home office or rep that would be available to at least discuss it by phone, FaceTime, or do something like that? If it turns out it's 4 o'clock in the afternoon and we got to do it now. What was the question?
So he was asking about support, saying that first time you're using this, it might be an acute emergent case. Is there what are the options if it's 4 a.m., 4 p.m. that you've now are interested in using this? You may have it on shelf but have not used it yet.
Yeah, believe it or not, if you have your rep's number, they usually have mine, and you'll be talking to the guy. And so, that's how I still have fun. I love hearing about the cases and how people walk through them, those kind of things. So, yeah, usually there's somebody who's going to talk to you very quickly about that. So
I think the other thing is that this device is not conceptually hard. So if you know how to use a catheter and a wire to cross the lesion, that's easy. Then you basically deliver the baskets. You take your microcatheter that's part of the system out, and then you're bringing in the basket. The hardest part to me was remembering how to load it in the basket. You basically have it deployed. You just push it backwards on itself and put it right over the wire. So the one really nice thing I can say about this is if the rep had showed you this once or twice in the office and shows your techs how to do it, it literally was, my partner that was terrified to use it afterwards, he goes, "Oh, that's it?" And I'm like, "Yeah, not a big deal. It's like truly pretty simple and straightforward to use."
2%.
And the LP would be a 7 French sheath, is that right?
Yeah, it's not for the baskets. The baskets actually go through an 018 lumen catheter that's very low profile, but the funnel is the same. So that's why you use a 7 French sheath for that, and you just put the funnel in the popliteal at that point in time. Good question. Thank you.
If I can add something, that's exactly how I used it for the first time. And my rep was in Dallas. I'm in Austin. So I just looked at the YouTube video they have on the website, and it was kind of like, okay.
But it's also how adaptability, grew throughout my lab with other physicians. I mean, they saw one case being done, and then they said, we can figure this out, and off it went. So,
right. And I think that one of the things to keep in mind is that, because some people will go, I can't get it on my back. I have to get something off the shelf. I want to get on my back. The reality of the answer is that you don't have an embolectomy catheter on your shelf other than an open surgical Fogarty. The other catheters don't take out emboli. And so you actually have a new device to be able to do things. And I tell people to realize that it decreases potentially your medical risk. Why? If you're a radiologist or you're a cardiologist, because if you have something you can't take care of and you've got to send it to thrombolysis, 20% risk of major bleed. If you're going to have it go to Fogarty, you now have to call in another specialist who now has to take them typically to the OR, and the family of the patient think you potentially did something wrong, and you've added that much more time to their hospital stay, where with this, you just get it all done at the same time. In the first in man, we of the 20 cases done at 6 sites, the average procedure time was less than 80 minutes, and the maximum lesion length was 30 centimeters. So they actually did very well on a learning curve. Yes, sir.
Nominal vessel diameters. What for the device?
So the LP is 2 to 4. I want to make sure I got 2 to 4, and then the fem pop is 3.5 to 6.
I see that there are a lot of rescue cases being demonstrated. Anybody in the setting of chronic SFA occlusion to use this device to decrease the clot burden?
Did you say chronic SFA occlusion?
Subacute chronic SFA occlusion. Elective cases.
That was what I was alluding to when you see both chronic debris and you can sort of unearth, in a chronic SFA occlusion, you might find that, some of the mid portion to that occlusion is just, acute clot and not all atheroma. And so you can actually unearth that. And so you're not necessarily having to treat the whole SFA. And like I said, one of my first case was actually a SFA occlusion, but it had already been stented. The stent was occluded, but there was, occlusion above and below that. So I found it very helpful for those.
Great. In the first in man, the oldest lesion treated was clinically, it's all by clinical presentation, right? So the oldest one by presentation was 8 months old. And they were able to clean out that entire thing. But, again, mixture of chronic and acute, those kind of things are typically there. I think that think the other thing is, who don't you do? And I guess I'll ask all you guys that, but I can tell you at our institution, who don't you do would be somebody that you have a really hard time getting the wire through. It acts like a really chronic CTO where you may be subintimal, those kind of things. I don't think that's where you want to do this. I mean, this is for a thrombotic lesion. The ones where your wire, I have my tech put it down, just put the wire down. She just spins the hydrophilic wire right through it. That's an easy call because I know if I don't do something, I'm probably going to embolize. And so I want to decrease that risk. So I go ahead and that's how we would do it. But I'll ask the
I think the other place is, do you have a landing zone for the basket? The funnel. So, one of the cases we'll talk about is an SMA, it's distal SMA. Usually, when an SMA embolus happens, it's, unless you're coming from arm axis, if you're coming from groin axis to get the sheath to stay put there, and the embolus is usually right at the middle cock, you may not have enough room for the funnel and to get it into it. And then the other places, a common iliac lesion, if you're coming and going antegrade, it's not really going to work. But if it's retrograde, you can do it. So it's just really about, do you have room for both the basket and the funnel, and then is it appropriately sized, because it's really indicated up to 6 millimeter vessels. Super.
These are just a couple other, just to show you the clinical versatility of cases that have been done. The first case is from Dr. Mike Backrack and his daughter Thecla, who's he's a vascular medicine cardiology type of guy, and she's a vascular surgeon, both in the same city, competing in Sioux Falls, but this is when she was training as a fellow. And this is a older lady that came in with an embolus to her right brachial artery, and you can see the occlude closure here on the brachial distal axillary. And you can see this actually was cleaned out with one pass of the Pounce through the common femoral artery. And I had somebody come up to me one time when I presented this case for him. They said, it's a brachial cut down for criminy. Who cares? Just to have done a Fogarty there. And I see these kind of patients in the office because being a cardiologist, AFib, those kind of things. And the thing you're trying to do is tell her, don't use your arm to go to the potty. To an 80-year-old lady, doesn't happen. So they have a significant complication rate just because they won't do what you ask them to do. And so this sometimes can add just a simpler technique for some of these patients. And then sometimes we're doing stuff that clinically we got to figure out where those limits are, because this is a patient that came in with a SMA occlusion, and they hem and hawed and delayed and finally took her for a Pounce thrombectomy and were able to clean that out with actually one pull of the Pounce thrombectomy for an SMA occlusion. I mean, without an open surgery, that changes potentially a lot, but we can't wait till the very end to do these things. We have to be able to treat these patients quickly to improve our clinical outcome for them. Any other questions for you guys? So one of the questions we get a lot of times is, so LP just came out. It's got a limited launch so that it'll be slowly coming out. But where do you guys see that in your own practice? I mean, what were you doing before this, and what do you think it will change to now? Lucas, what we start at your end?
I mean, before it was the CAT RX, which was a very frustrating experience. And I think, as we talked before, I think this is like at least 80 to 50% more efficient than competitors. So it has definitely a place, and it changes the paradigm of how I go into a case for that. Because as I said, before that, there's a high chance that this patient ends up in the ICU with a lysis catheter. So that changes not only that day, that changes the risk factors, the possible complications. It changes your next day, your plan for the, your cases for the next day. So, you end up finishing a procedure that kind of takes in totality more than 12 hours in 2 hours in a predictable fashion. So I think that's why it's very good.
I'd say from my perspective, I mean, where we were with every tool we possibly could think about putting down into a tibial vessel, trying to, get clot out. I mean, the LP, I think, changes the game there in as much as it will help protect or help us treat embolism as much as acute thrombus. And so that's just a different play for the device, but I think it'll work well. And that's where I see some advancement of it, and then potentially in some arm cases.
So, having been, Ken Oriole being my senior partner, I've done a ton of lysis, but once we started losing the Casson wire and the ProStream wires, now lytics into small 2 and 3 millimeter tibials, you can't do it anymore. So that's become tough. And I'd say the CAT RX has been sort of my go-to device, but it's not perfect. And usually if I get one vessel open, I stop. To me, I'm hopeful that I get the LP soon, but to me, the difference is the ease of using it in a single pass. Like, I'm now likely to put it in all 3 vessels to get it, because whether you're doing atherectomy or anything else and you get that calcified chunk in a tibial vessel, I would challenge that we've not had a great endovascular solution. So you're crossing it, you're stenting it, you're putting big guides down there to aspirate it, but a lot of times you're just leaving it and saying, I hope the foot's okay.
So I oftentimes will get asked, can I put this in my OBL? How cheap will you give it to me? So I'll give you a good story, because there was a guy that one of the salespeople approached to put it on the shelf, the OBL, and he said, no, we don't put expensive devices on our shelf. That's just the way it is. I do everything like that in the hospital. And 2 weeks later, the rep got a call from this gentleman who had a patient that had an acute thrombosis in the OBL. And he said, hey, are you in town? Because I got this patient I'm going to have to transfer to the hospital, but her leg's dead, and I need to do something if I can quick. And, we don't have anything that'll work here. And so the rep just happened to have the trunk stock. So the rep went over very quickly. And the patient had a thrombosis with a SFA popliteal, and they couldn't see any runoff. So they actually did 2 pulls through the fempop and tibial region and cleaned that patient out, and she was discharged from the OBL. And so I challenge people that have OBLs that how much was the complication going to be worth for you versus the potential litigation. So, when you don't have to have a drive unit, to store, you don't have to have another device that you hook up that you have to store, that the shelf space or the footprint is very cost effective. So that gentleman said at the end of that case, you know what, maybe we do need 1 or 2 of these on the shelf here. So I think that's really going to, for OBLs and ASCs and things like that, where you really can't afford to have complications, because that defeats the whole purpose of being off the hospital campus. And I think that's going to be really important from that standpoint. One of the questions, go ahead, I'm sorry. Good question. So these do not get approved without testing, without a doubt. So in the animal testing, what you look for is damage to the elastic lamina. That's what the FDA wants to look for, to see, hey, is this going to stimulate some type of propagation of restenosis, things like that. It was far away in the acceptable realm and equal to the predicate they used. Again, more than carotid protection, because carotid protection we used to utilize for this. And occasionally you'd get it work, but most of the time it wouldn't. There's a secret sauce to this. And it's actually also the fact that you have 2 baskets make it much more efficient from that standpoint. Good question. Yes.
You mentioned OBL and ASC. Is there a differential in reimbursement in one environment versus the other?
Yes, very much so. So OBL, probably have one of the OBL guys talk to you about it, but you get reimbursed for the procedure, period. You don't get reimbursed for the multiple different devices. An ASC is, and the regulation, depending on the state for an OBL, is far lower, and you don't get near what you get in a hospital. That's one of the drives for that. ASC is a lower reimbursement as well. There's a little bit more complexity to the reimbursement from that standpoint, and certainly without a doubt, hospital's the highest reimbursed environment. Then it comes ASC, then it comes the OBL, and it also, if you look at your hospital administrators, because I used to be one of those, and they go, "We're losing money on your cases." You have to remember that. Besides what that reimbursement says, they get about almost $2,000 for just being a hospital for each procedure. So you're almost, unless you're using a bunch of devices, which is not cost effective. Like if you're putting an angiojet in, and then a penumbra, then, the Pounce, and then you're putting a stent and all those kind of things, that you can take away the profit margin pretty quickly. But I think the biggest thing from our standpoint at our institution was, number one, the patient. Get the patient done as safely and as quickly as possible and have a good outcome. Number two, think about price. So if you have best device, that's probably going to be the best device to get your most economical outcome, because we don't want to put that patient in the ICU if we don't have to. We hated thrombolysis because of the complication risk and the litigation risk. And then we want to get that patient out of the hospital as quickly as possible. Why? Because the biggest reimbursement is those first couple of days, and then, they're just hanging around. And your next patient you bring in will have the highest reimbursement. So your revenue generation is highest when your length of stay is lowest. Not because you're just getting that patient out, other than you can bring somebody else into that room. Good question.
If I could go back to a little bit to that, I think a lot of it also has to do with technique. If you go straight distally and try to get the whole thing at once, I think there's risk is there. I think if you take it proximal to distal, and I usually try to divide things in three, divide the vessel in three passes, I haven't had an issue.
And then whenever you see a new device, you want to know, what's the failure mechanism? What's the worst case scenario that I can do from this standpoint? So let's say you had a marble down there and you can't get the marble out, and you've got it in your basket, and you've got it pulled into your funnel, and you just can't pull it out. Rare occasion from our experience, but theoretically possible. The worst case scenario is that you pull it to the arteriotomy and you do an arteriotomy and pull it out. But for just a little bit more robust type of embolus, if you needed to, you just take out your sheath, and the wire for the baskets is a very nice one. You just put a bigger sheath upon that and then pull it out of a bigger sheath. If I did that, I'd go up to a 9, because that gives you a much greater area. But I can tell you, talking to the people that have used it, and you guys, it's been almost unheard of, just a case here or there that they've had something that robust that they've had to upsize their sheath. How about you guys?
I've had some stuff get caught in the sheath, and then you have a little, to backtrack, Sean said using the Terumo sheath is advantageous because you can pop off the back cap, and I've had a time or two where you pop that off and you're not getting much flow. But I haven't had anything, so to speak, fall out of the system and get lost in the vessel.
Super. Other question? Well, we're going to give you 5 minutes to have fun while you're done with your lunch and on to the next ISIT session. Thank you so much.